RN Link presents Digestive Diseases webinar. You can also obtain the CU certificate for $50 by clicking the link below on the description section. The presentation offers 2.5 CU approved by BRN, ACDIS, and AHIMA.
Okay. All right. Well, welcome to Digestive Diseases, presented by RN Link, which is myself and Christina. Our learning objectives for this training session is we're going to define some pathophysiology associated with GI disorders, pancreatic disorders, as well as our hepatic disorders. We're going to understand the coding guidelines associated with each system. We're going to evaluate the query practice brief update from AHIMA and ACDIS, review some case scenarios for the most common disorders associated with, I guess my timer must be on, which I didn't know. Review case scenarios for the most common disorders associated with GI, hepatic, and pancreatic systems, and then discuss some query opportunities that we're going to go through for MCC and CC capture of diagnosis and trigger words that are associated with the query opportunities. I do have some fiscal updates of the ICD-10, CM, and PCS codes, as well as, and then any Q&As at the end if you think of anything. Okay. Our disclaimers: the presentation is designed to provide tools to communicate information about clinical documentation, coding, and compliance in an educational structure. The presenter or presenters are not providing or giving legal assistance or advice, but offer sensible and useful information and tools to obtain compliant results in the area of clinical documentation and coding. The educational materials provided in this presentation are carefully explored for its accuracy and usefulness, and best practice results and achieving outcome will differ at each hospital or facility and every clinical situation. So just keep that in mind. Let's talk about the GI system. As you can see, there's a lot of different organs associated with the GI digestive system. So what I have been reading in all the medical journals, it's a very complex system, as we all know as nurses, and it's composed of 4 histologic layers: your mucosa, submucosa, muscularis externa, and serosa, and adventitia. Titia. I don't know how to say that. Anyway. The mucosa is a single layer of epithelium known for absorption, and it secretes your mucus, electrolytes, water, and your digestive enzymes, and it also houses the endocrine glands. So the submucosa is a connective tissue layer. This houses your blood and lymphatic vessels to support the GI tract, and the Meissner's plexus is found here. I know that in other webinars that we had, there were certain, especially for ortho, they have different plexus, different anatomies. So it's really helpful to have that information when you are a CDI reviewing certain ortho cases or GI cases when you're starting to review charts. So I think it's really important to add any of the plexus information that's listed within each body system. Your muscularis externa is 2 smooth muscle layers. There's an inner circular layer and an outer longitudinal muscular layer. And the Auerbach plexus is found in this layer. And the muscular layers coordinate with that plexus to control the peristalsis. So that's where all this information comes from. If you see GI docs writing the Auerbach or Meissner plexus, then you know what they're talking about. They're discussing the layers in the mucosa, the GI tract. And then, of course, your serosa and adventitia. The serosa is a smooth membrane that is a thin layer of connective tissue, but it secretes serous fluid to lubricate the internal organs. So fluid reduces the friction, of course, during movement, right? And it also covers the intraperitoneal organs, and the adventitia covers the retroperitoneal organs and holds the structures together. So that's why we have these 2 little histologic layers or connective tissue layers, as you would. Now, the GI tract has what? The oral cavity, your pharynx, esophagus, stomach, small intestine, large intestines, and your anal canal. And the main functions, of course, is ingestion, digestion of food, nutrient absorption, your secretion of water and enzymes, as well as excretion of waste products. And we all know our waste products is your urine and feces. Accessory organs. Now, this is your teeth, tongue, salivary glands, liver, gallbladder, and pancreas. And we're going to go into depth regarding the liver and gallbladder and pancreas in the next section for A&P. So let's discuss each GI tract oral organs. So we'll start with the oral cavity here. And there are 4 functions that the oral cavity has. It senses analysis of food material before swallowing and processing the food via the teeth, tongue, and palates. Also provides lubrication by mixing food with mucus and salivary gland secretions. And there are 3 pairs of your salivary glands, your parotid, sublingual, and submandibular. And they lubricate the mouth to prevent friction between the mucosa, oral cavity, and food materials. So it's all about lubrication when it comes to your oral cavity. Your pharynx is the passageway that the food material goes into the esophagus during swallowing, and the nasopharynx and larynx close to propel food to the esophagus. The reason why the nasopharynx and larynx close is we don't want it going in our trachea, right? We want it to go in the GI tract. Now, your esophagus is the main transport of the food to the stomach via peristalsis. The upper third of the esophagus is predominantly skeletal muscle. The middle is a mixture of skeletal and smooth muscle, and the lower 1/3 is primarily smooth muscle. Then, of course, your stomach. This is where the food is stored. Yeah?
Mm-hmm.
You have a question?
No.
No. Okay. Okay. And so in the stomach, your food's stored temporarily there, and then it breaks down all the food, right, through mechanical breakdown with the acids and enzymes. It also stores food stems from the stomach to change its size. So with all the food that's in there, your stomach can grow big or grow small, right? The lesser curvature of the stomach is about 10 centimeters in length, and the greater curvature is roughly 40 centimeters. So that's why the stomach can change shape when it's processing, breaking down the food. And the stomach has 3 muscle layers. It has an inner oblique layer, a middle layer, and an external longitudinal layer. And the contraction relaxation mechanism assists with the churning, mixing of food to form chyme. And that's our acid that passes through the stomach into the small intestine, consisting of gastric juices and partly digested food. So chyme is the big piece of the pie when it's breaking down the food to move it toward the small intestine. And then when it comes to the small intestine, we have 3 segments, the duodenum, jejunum, and ileum. The duodenum is the one that receives the chyme from the stomach and the digestive material from the pancreas and liver. Jejunum is where the bulk of the chemical digestion and absorption takes place. And your ileum is the last segment, which also aids in digestion and contains the ileocecal valve. That's the sphincter that controls the material flow from the ileum into the cecum. Now, the small intestine has, that little villi with multiple microvilli to increase surface tension for optimal absorption. So that's where all these capillary networks that absorb nutrients to the hepatic portal circulation. So everything is intertwined when it comes to the GI tract, even though the accessory muscles with the liver and the, your pancreas and whatnot, they're all part of the complex system. The intestine have both endocrine and exocrine glands that produce hormones, enzymes, and alkaline mucinous material. Now, some of the hormones that the small intestine may release include your gastrin, your cholecystokinin, or CCR, gastric inhibitory peptide, or GIP, somatostatin, and your motilin, and vasoactive intestinal polypeptide, or your VIP. Enzymes to aid in the digestion include your lipase for fat digestion, your peptidase for peptide breakdown, sucrase, maltase, and lactase for sucrose, maltose, and lactose breakdown. Say that 3 times fast. Okay. Are you guys with me still?
Yep, just trying to stay quiet.
Yeah.
Okay. No problem.
We're here.
All right. Okay. Let's move on to the hepatic system. The liver is the largest organ and gland in the body, and it's an accessory organ to aid in digestion. Of course, it consists of 4 lobes, your larger right lobe and left lobe, and then it has a smaller caudate lobe and a quadrate lobe, excuse me. Lobes can be further divided into 8 segments, which are made up of thousands of smaller lobes, or your lobules, right? And these lobules is the duct flowing toward the common hepatic duct, which drains bile from the liver. So with the big, larger lobes, they have the lobules, and the lobules are the ones that drain the bile from the liver with the common hepatic duct. Now, the functions, of course, production of bile to assist in emulsifying your fats and various lipids for optimal digestion. It also regulates your blood glucose levels, creating and storing essential nutrients. That's where your vitamins come into play, your D, E, K, and B12, as well as copper and iron are stored in the liver. Removes bacteria from the bloodstream and filters blood to remove toxins and byproducts and any other harmful substances, as well as regulate blood clotting. And that's a big piece of the pie when it comes to liver, because we see a lot of coagulopathy with our liver cirrhosis patients who are in liver failure. The liver structures include your common hepatic duct, which carries bile out of the liver. Your falciform ligament separates the 2 lobes of liver, and it connects it to the abdominal wall. So it's like keeping it in place. Your Glisson's capsule is a layer of loose connective tissue that surrounds the liver, and it has relative arteries and ducts associated with that. Hepatic artery is the main artery to supply the liver with oxygenated blood. And then your hepatic portal vein is the main blood vessel that carries the blood from the GI tract, gallbladder, pancreas, and spleen to the liver. And then your peritoneum, that's our membrane, right, covering the liver that forms the exterior. All right, now let's take a look at the pancreas. So your pancreas is found in the abdomen, and it's behind the stomach, and it's in the left upper quadrant, right? It's surrounded by the small intestine, liver, and spleen, and it's a flat pear shape in appearance, and it's divided into the head, neck, body, and tail. This pancreas plays an essential role in converting food into fuel for the body's cells. So it has 2 main functions. Your first function is an exocrine function. These contain exocrine glands that produce enzymes for digestion. So mainly it's your trypsin and your chymotrypsin that digest proteins. Your amylase assists in the digestion of carbohydrates. And of course, your lipase breaks down fats. So when food is entering into the stomach, the pancreatic enzymes are released into the pancreatic duct, joining the common bile duct to form the ampulla of Vater, and that's located within the first part of the duodenum. Now, then bile from the gallbladder is released with the pancreatic enzymes in the duodenum to digest your fats, carbohydrates, and proteins. So there's a lot of digestion going on with enzymes with between your stomach, your liver, and your pancreas. Now your endocrine function, this is where your islets of Langerhans, they are there, they are listed, are part of the pancreas, and they create and release hormones. And what do? Mainly for insulin, right? So your islets of Langerhans release insulin to lower the blood glucose levels, and they release glucagon to raise the blood glucose levels if your blood sugar is too low. Normal blood glucose levels are crucial to maintain proper functioning of the brain, liver, and kidneys, and we all know that from nursing. Okay. Now your oral cavity, with the different disorders that you see, your oral cavity, you may have salivary gland tumors, pleomorphic adenoma, mucoepidermoid carcinoma, or Warthin tumor. I've seen those documented, Warthin tumors, by surgery oncs and GI docs in prior reviews I've done. So I've seen those. Your esophagus, of course, scleroderma may develop. Esophageal dysmotility is a big one with esophageal strictures. Your esophagitis, alkalasia, and esophageal varices. Of course, we'll see esophageal varices, with the GI bleeders, especially if they have alcohol abuse or dependence. And then, of course, your stomach, you may see gastritis. H. pylori infection is another one. And then autoimmune diseases too. They said it could be related to pernicious anemia. I thought that was really interesting. I never associated anemia with the stomach itself. So you learn something new every day. When it comes to your small and large bowels, I said celiac disease, that's a pretty big one now, because the body just can't digest any, psyllium or whatever that enzyme is to break down that food that has that particular, can't even think of the word I'm looking for. Anyway, but yeah, I think that's coming out more and more. Where gluten, thank you. Gluten is out there. So you got to have a lot of gluten-free stuff, and that's part of the celiac disease process. Your Crohn's disease, of course, or ulcerative colitis is another one. There's also, your congenital disorders, Hirschsprung's disease, intestinal atresia, intestinal malrotation, and pyloric stenosis in infancy. So if you do work with little babies at all, or at one point in your life, they may have some congenital issues as well with their GI tract. Okay, now let's look at some coding considerations for the GI system. So anemia, of course, is the biggest one that we know, right? It's caused by chronic disease states and or physiologic variables such as your age, sex, altitude, smoking, and or pregnancy status. The different types that we see, of course, iron deficiency, your vitamin deficiency, aplastic or hemolytic. Some of the signs, symptoms, and physical exam findings you may see depend on the severity of the anemia. So with mild anemia, you may not exhibit any type of symptoms, but if you have fatigue, weakness, paleness, and or even short of breath, may exhibit a severe anemia. And when it comes to your diagnostic workup, you see a lot of CBCs being drawn, serial CBCs. They, of course, they'll do a UA and even a fecal occult blood testing. Treatment, it depends on your etiology. So, if, say, a pregnant mom, they're dropping their iron, levels are low. So they're going to put them on iron tablets, right? To keep them going, prenatal vitamins, iron tablets and things, just to keep their blood counts up. But you always want to query for the type of anemia, even if it's a chronic disease. If patients have CKD, they have renal disease, they're a CKD stage 2 or 3A or whatever, or they're end stage. You always want to make sure we get that link. If they're documenting anemia, that they are linking it to the chronic disease state, if it's CKD or if it's another chronic disease that they may have. When it comes to American Hospital Association Coding Clinic, second quarter, and this was 2023, pages 17 and 18, the provider must document a causal relationship between anemia and chemotherapy for D6481, which is anemia due to anti-neoplastic chemotherapy, to be reported. So if the doc's writing anemia and they have severe anemia and they came in and their H&H is like 7 and 19 and they're going to give them blood transfusions, and they're a cancer patient, they were undergoing chemotherapy on the outpatient side, but because their counts were so low, they have to admit them to give them the blood transfusion. You always want to make sure the doc's associating that severe anemia with the chemotherapy, if it's warranted. And you will capture an MCC in that respect with that link. The other coding clinic I have here from American Hospital Association, third quarter 2019, page 17 states, when acute and chronic blood loss anemia are both present, you're only going to assign the code for acute blood loss anemia, and I didn't put it in there, which is D62. That's your ABLA query, your ABLA, acute blood loss anemia diagnosis code is D62. So GI bleeding, we always see a lot of those too. The docs may say, oh, we got a GI bleed. We don't know where it's at. They may say they have melena, hematochezia, hematemesis, or your occult GI bleed. They're not sure what's going on, where it's at. The signs and symptoms and exam documentation may see black tarry stools, they're vomiting blood, or they have bright red blood per rectum. Diagnostic workup, of course, usually it's an endoscopy, whether it's upper or lower or both. And of course, they have a positive OB test, fecal occult blood test. And then again, the treatment depends on the acuity and severity of the bleed. Sometimes they'll give blood transfusions. They may just do serial H&Hs if it's not too low. Most GI bleeders, though, they usually get at least one blood transfusion that I've seen, because they are really low, their H's and H's. They even give them IV replacement. They may even give them, if there's a religious belief that they don't accept blood transfusions, they may give some plasma, or they may just give them IV iron. So just keep that in mind too, depending on what their religious background is, because that will change the treatment plan for the providers, because they're going to adhere to their patients' wishes. Okay. Your AHO coding clinic, first quarter 2023, page 13, says when both anemia and GI bleed are present on admission and both meet the definition of principal diagnosis, either condition can be sequenced first. So sometimes in this scenario, I have used the acute blood loss anemia as the PDX on a couple cases that I reviewed. And then I was discussing it with the coder, and the coder says, yeah, I agree with that, Anne-Marie, because they really didn't find the GI bleed. They didn't find where the source was. And the doc says, we still can't rule out that there was a GI bleed, but they never found the source. So we ended up using the acute blood loss anemia for that particular case, and we put the GI bleed as a secondary on that with the coding sequencing for that particular case we reviewed. And even the coder's like, yeah, that's a valid point. That was at a contract company I worked last year. So it was really interesting that we both agreed with it. Query opportunities, of course, your etiology of GI bleed if known. Like I said, sometimes the GI docs can't find the source when they're doing endoscopies. And you may have an unspecified GI bleed code if the provider didn't document anything else listed above. When it comes to your intestinal obstructions, I think this is really a big one. Your intestinal obstruction could be your K56.60 dash. There's a dash there because it's broken down further in the code set. So you may have unspecified, you may have partial, or you may have complete. So that's why there's an additional code number on that intestinal obstruction code. Your paralytic ileus is your K56O. Ogilvy is K5981. Intussusception, K56.1, and your volvulus, K56.2. I think it's really important that the GI docs and the general surgeons, they really get together, especially if it's an intussusception or a volvulus. They will bring him, redline him to the OR to get that taken care of immediately for that patient. Signs and symptoms that you may see: abdominal distension, nausea, vomiting, or constipation. Usually they're always doing x-rays, CAT scans. I notice they do a lot of abdominal ultrasounds as well. I see that besides the abdominal x-rays. Treatment, NPO usually, because they always have an NG tube inserted in them to decompress the stomach. See what's going on in there. Of course, IV fluids, electrolyte replacements. If it's persistent, though, they may need surgical intervention. So again, it depends too on how severe that intestinal obstruction is. If it's partial intestinal obstruction, say they had prior surgeries, woman had a total abdominal hysterectomy or something years ago, and all of a sudden she's having constipation, or abdomen's distended, find out she's got a little obstruction going on, a partial. So they're going to give her conservative treatment, and usually NPO status, IV fluid maintenance, and NG insertion to see if it clears up. Okay, and then run the serial diagnostic imaging tests. When it comes to AHA coding clinic first quarter, oh, I didn't put the year on there. My apologies. Oh, 2020, I have it in there. Page 29. New codes were introduced for fiscal year 2020 to describe Ogilvy syndrome and other specified functional intestinal disorders. So Ogilvy syndrome may be described as acute colonic ileus and acute colonic pseudo-obstruction, ACPO. You may see that abbreviation within the GI docs documentation. This is not the same as a chronic intestinal pseudo-obstruction, so it's different. So they're saying one is colonic, one is the colon itself, but the other one is any intestine that's associated with the pseudo-obstruction. So you do have different codes for these. And of course, the query opportunity would be the type of obstruction, whether, like I said, partial, complete. It could be a paralytic ileus and not an obstruction. And usually you'll see intestinal obstructions. What I've seen mostly is because they had surgery. You know, they had surgery years ago, or they had recent surgery within 3 months or 4 months. So they may develop some type of obstruction at that time as well. You never know. Hopefully not.
Also, when I was still working and we were using the 3M, and I'm just typing the syndrome, and on the list, it doesn't give me the Ogilvy syndrome. So
Yeah.
I found out that it has to be like an obstruction before, before you're able to get that syndrome. So I don't know now whether they changed that in 3M, but most of the time, if you encounter this, the doctor will document this, but it's just that when you're coding it, it's so it's not easy to find that syndrome unless you
Right,
put there like colonic obstruction. So, and then it will come out. So,
right. They
just an
did update.
FYI. Mm-hmm.
Yeah, the 3M, they've been updating a lot of codes. I mean, there were some code updates, I think, just this past month, at the beginning of April, for April 1, for the, twice a year coding, the updates they do now instead of once a
Mm-hmm.
year with CMS. And I think if you do type in syndrome now, and it'll give you, and then you can spell it out, because it has its own code now. So
Okay. Yeah.
hopefully you can get it that way now, I believe,
Mm-hmm.
because of the code updates that they did a few years ago. So,
I'm obsolete.
when in doubt, though, start with obstruction and go to intestinal and see
That's
what
right.
you get.
Christy.
It's just a year ago.
I know. So,
Yeah.
it's just, I think everybody's, even though 3M should be the same for all, of course, all the organizations, because they all use it, right? Inpatient and outpatient alike, in certain situations. So, okay. All right, pancytopenia. I like querying for this. Do it all the time.
It's an MCC, right?
When it's associated with chemo, yeah,
With chemotherapy,
absolutely.
yeah. Otherwise, it's
Yeah.
a CC only. Mm-hmm.
So pancytopenia is defined as a finding that results from a disease process. So it's not a disease pancytopenia. It's not considered blood dyscrasia type of disease. So the providers you may see pancytopenia, anemia, leukopenia, neutropenia, and even thrombocytopenia. Signs and symptoms in the physical exam. The clues that you may see noted in the physical exam, they may have rashes that are related to drug interactions, infections, or malignancy. They have oral ulcers that may indicate they're immunocompromised. They may have like SLE, right? Systemic lupus erythematosus. They may even have some lymphadenopathy to indicate that they have immune thrombocytopenia. And they may be jaundice because they have liver disease, right? So with the diagnostic workup, they're usually doing your CT scans from chest, abdomen, pelvis. They do the whole scanning. They're going to do serial CBCs. They even may draw your inflammatory markers, like your ETSED rate, your CRP or ESR, C-reactive proteins, your CRP. You definitely want to keep an eye on those, because if there is some type of inflammation going on, they may be because of autoimmune disease, right? Like your SLE. So you definitely want to keep an eye on the inflammatory markers as well. Treatment, of course, goes back to your underlying etiology, like for any GI disease state we have. They may give blood transfusions. They may give RBCs and platelets. CT scanning for potential splenomegaly or lymphadenopathy. And I think it's really important. Like I said, you got to keep a close eye on your labs, because that will definitely give you the clues, as well as the physical exam findings by the provider when they're documenting it. For AHA Coding Clinic, third quarter 2023, page 3, assigned code D61811. It's other drug-induced pancytopenia, followed by T50.99A, adverse effect of other drugs, medicaments, and biologic substances, initial encounter for pancytopenia due to radium-223 treatment. So if they're getting radiation treatment and they develop pancytopenia, that's what this coding clinic is stating. You want to code the other drug-induced pancytopenia with the adverse effect, because the medication, the treatment that they gave them, the radiation treatment, was giving appropriately as prescribed by the provider, right? That's like taking chemotherapy medication, tamoxifen. They still give tamoxifen, I believe, for breast cancer patients, right? Even though they may have
Yeah.
surgery,
Yeah,
they're
they
still
do.
getting that,
Mhm.
right? They still do, right?
Yeah.
So they're still on that for probably 5 years, 3 or 4 or 5 years, depending on what type of, breast cancer they have. So it's really important that you keep an eye on that, because maybe that can cause, your oral chemo meds can cause pancytopenia too, not just your radiation or not just your IV chemo meds. So just keep an eye on that too. And that's a little hint to, trigger when they're on meds, especially if they went through their chemotherapy and then they had the surgery. Another coding clinic from first quarter 2019, page 16, states that the ICD-10-CM classification does not prohibit assigning code D61.818 other pancytopenia, along with the code from category C92, which is your myeloid leukemia. Pancytopenia is not inherent in acute myeloid leukemia or AML, and therefore both conditions are coded when they meet reporting requirements. So there are certain rules that say exclude notes 1, you can't code this diagnosis with this pancytopenia, say. All right. But in this particular example from Coding Clinic, the AML is not inherent to the pancytopenia, so you can code the pancytopenia along with your acute myeloid leukemia diagnosis. You always want to look at your nosology notes in your encoder and your 3M to see what, it's like, no, you can't have this code with this code. It'll tell you it's exclude 1 notes. But if it has an excludes 2 note, usually you can capture both of those diagnoses. And sometimes your excludes 2 notes are where your queries could be as well. Those are potential queries if the doc didn't write it, the provider didn't write it. So that's just a little tidbit when you're looking at your 3M encoder. And of course, our query opportunity would be your pancytopenia associated with chemo. And then if anemia, leukopenia, thrombocytopenia are documented by the provider, the CDI team and the coders can list the pancytopenia within the code set. Because when you're going through your encoder and you have all these, it'll automatically link it to your pancytopenia. Because those are the 3 items that you need listed. So you're
So we
not
don't need to.
introducing anything new. I'm sorry, Christy, go ahead.
Yeah, so we're not gonna query pancytopenia if the doctor documents this anemia, leukopenia, and thrombocytopenia, because it defaults to pancytopenia, right?
Correct.
Okay.
Yeah.
All right.
Wait. I have a question.
Yeah.
Too, actually. Okay, so if they're just documenting that the patient has the anemia, the leukopenia, and the thrombocytopenia, but they're not saying pancytopenia, we can go ahead and code the pancytopenia?
Yeah, because
Yes.
if you go through the encoder, it'll bring you to that pancytopenia code.
Okay.
It will.
Okay.
Yeah, it will default to that.
It'll
As long
default.
as these 3, yeah. But sometimes they'll just put their anemia and thrombocytopenia and then low WBC. It's like, okay, are you talking about pancytopenia? But if they say leukopenia, then I think it defaults to pancytopenia.
Right. Right.
All of them, all these documentations, diagnosis should be documented by the doctor.
Yeah.
Now, if you need to possibly query for it, because I did have a case where the H&H met and the platelets met, the WBC was just slightly above the low normal, so it wasn't, real obvious. And I went to do a query for it, only because the attending had not documented it, and HEMONC was kind of implying but not saying it. And so I included the neutrophils that I had, and I actually had the doctor come back and say, well, the white count didn't meet, but the neutrophils did.
Yeah.
And
Right.
so I wonder how that could be like better, or should it just not be done if the white count is above the normal?
And that's the other thing. So there's different schools of thought, Debbie, right? And that's the problem. Certain providers will go according to the neutrophil count. If it's low with the anemia and the thrombocytopenia with the platelets and H&H, but other providers will only use the white count, H&H, and platelet counts for pancytopenia to diagnose it. So that's the problem. There's different schools of thought out there. So
Yeah.
even though everybody says, oh, you can use the neutropenia too, well, some of the docs don't use that. They're going to go according to the white count, H&H, and your platelet.
Yeah.
Okay. Yeah. And then she
Yeah.
called me she called me to discuss the query, and I ended up withdrawing it because she didn't feel that it met based on the white count that was just above normal. Like if it was the cutoff was 12, or the cutoff was
10 to
8.
12.
I'm gonna say if it was 8, the patient was like 8.5.
Oh yeah.
It's just
Yeah. Yeah.
all right.
And that's the thing. I look for the white count before I look for the neutropenic lab, the neutropenia lab, because a lot of docs go by your white count, H&H, and platelets. So even though I think the hemocs will look at the neutropenia
Yeah.
as well, and they may accept that over the white count level, to be honest, but that's their specialty, right? So they're going to look at that more specific lab, that neutropenic, see what that neutropenic level is.
Yeah. Okay.
All
Because
right.
the neutrophils were low.
Yeah.
Right. Yeah.
But if they
usually
see
they are.
WBC,
Yeah.
if they see the WBC is not really low.
Yeah, and I can't remember what that cutoff is on the WBC for it. Don't have that in my head at the moment, but it was like just above that.
I think it's 4. Isn't it 4 to 10 or something?
Yeah, there you go. I'm like, what was
and
the
it might
number?
have been like 4.1 or 4.2, and then they
the
will give it to you.
WBC,
Right?
Yeah, the WBC is actually 4 to 10, something like that.
4 to 10. Yeah. Yeah.
Yeah.
I'll go after it if it's like even 3 point. If it's under 4, I will go after it. Like 3.9, even though it's close to norm, I'll go after it.
Especially if the neutrophils are low. So
or something. It was just barely above normal.
Yeah.
Right.
Yeah.
Okay. Thank you.
You're welcome. Like I said, there's different schools of thought out there. That's for sure.
Yeah.
Yeah.
Okay. All right. What am I doing? Jumping the gun here. Okay. Acute liver failure. Provider terms. You may see them right. Acute liver failure, subacute liver failure, or chronic liver failure. As you can see, I brought in the days and the weeks associated with the different types of liver failure. I think that's a little helpful too from a CDI perspective. It's like, okay, is it acute liver failure? And it usually occurs within three weeks. Is it subacute? That usually occurs in 21 days to up to 26 weeks. And then if it's after 26 weeks, I believe that's 6 months, they have chronic liver failure. Okay.
Yeah, because sometimes I query that acute liver failure and the doctor will document subacute liver failure, which I think defaults to acute liver failure, but they make it more specific, like it's subacute. So, yep.
Right.
It's very helpful.
So more specificity is key when it comes to liver failure too. Causes could be medications, of course, any Tylenol toxicity. Viral hepatitis is another big one, and alcoholic hepatitis, your autoimmune hepatitis, as well as Budd-Chiari disease, malignancy, and or sepsis. Definitely your any of your hepatitises can cause acute liver failure. Signs and symptoms and some of the physical exam findings, they're usually non-specific symptoms. Tired, fatigue, malaise, not eating. They're constantly nauseous and vomiting, or they have some pruritus going on. May have some right upper quadrant pain, may not. But with progression, they can develop jaundice and or ascites. So your workup usually is your LFTs, right? Your ammonia levels are a big thing, especially if they have liver cirrhosis with alcohol abuse or dependence. PTINRs, they're always doing that to see where your blood clotting is, right? You want to make sure if it's too elevated. They may develop DIC down the road if they do have super therapeutic PTINR coagulopathy going on, and they check out a fibrinogen, so they may develop DIC. Your abdominal CAT scans and abdominal MRIs, they will do those from time to time. I usually see more CAT scans done, serial CAT scans than MRIs. Depending on your hospital, if they have the equipment to do the MRI, abdominal MRIs. Some community hospitals do not, they just do serial CAT scans. Or they'll do x-rays, but x-rays won't give them a lot of data. The providers usually don't order those for that particular reason. And usually your treatment, of course, it's based on etiology like everything else. Liver biopsy may be needed for definitive diagnoses. So, and your serial lab testing is above. So sometimes they may do a liver biopsy, sometimes they may not. What I've seen, if they do a liver biopsy, it's usually because they have a mass in there. There's a mass. They find a lesion, a mass, and they don't know if it's cancer or if it's a cyst or it's, a benign cyst. They will do a liver biopsy, but if they're having some problems with coagulopathy, they usually won't, because what's going to happen if they do a liver biopsy? They're going to bleed more and they can bleed out and unfortunately die. So very rarely do you see liver biopsies performed on these patients. American Hospital Association Coding Clinic, first quarter 2022, page 52, states that the encephalopathy that occurs with liver failure is metabolic due to toxins generated within the body. So you can have your metabolic encephalopathy associated with acute liver failure, right? Sometimes they may be very somnolent. They're confused, your AMS, so you could get a encephalopathy code. It may not be hepatic. It could be hepatic. Usually docs will write hepatic encephalopathy with acute liver failure or subacute liver failure. So you do have that captured, but it also could be a metabolic encephalopathy as well. So the other coding clinic, first quarter 2021, page 13 states, when documentation states toxic metabolic encephalopathy secondary to acute on chronic hepatic encephalopathy, you assign codes K72.00, which is acute and subacute hepatic failure without coma, and K72.10, chronic hepatic failure without coma, as well as G92, which is your toxic encephalopathy. So you're capturing your acute, your chronic liver failure, as well as your toxic encephalopathy for those particular patients. I think it's always important to clarify the encephalopathy too, as we all know, in the CDI arena. And it can be tricky with liver failure. Based on how the providers are documenting it.
Especially when there's not any true encephalopathy.
Well, there you go.
That's true.
That's right. Right.
Mhm.
And I've
Because I've
seen
also
that.
had recently a couple patients with normal ammonias.
Mhm.
Right.
LFTs are, like 20 over 30 or, 30 over 10 or whatever their LFTs are. And pretty normal coagulopathy studies, and they're documenting acute liver failure.
Mhm. Mhm.
Right.
And that's been a challenge.
Yeah.
And
Yeah, usually.
like some hospital, like in our facility, my previous facility, they would ask us to what do you call validate with the
Yeah,
doctors.
Yeah,
Mhm.
clinical validation. Yeah, that's when you
Validation,
send
yeah.
that. Absolutely.
Yeah, just to find out, when he says yes, it is, nothing you can do about it. He said it is. So at least, we did our part to clarify based on the clinical documentation that the doctor put in the chart. So,
Yeah. Yeah, exactly.
Right. Yeah, I like when they write hepatic encephalopathy with subacute liver failure. And then they're treating, and then the ammonia levels are all normal. I was like, really?
Yep. That's what I
Yeah.
did. Really? Okay.
Seen that. Yeah. Seen that a few times. Yeah. In my current contract position, I'm working. Okay. Pancreatitis. You may, doctors say acute pancreatitis, and usually that resolves with treatment. Patients may have chronic pancreatitis where there's irreversible damage to the pancreas itself. Or you may even see a pancreatic pseudocyst. And that pancreas, if they got a cyst of the pancreas, that's a CC capture for us, which is nice. They added that in, I think, last year or the year before. And some of the causes of pancreatitis could be, of course, obesity, alcoholism, any nicotine or drug addictions, cystic fibrosis, elevated triglyceride levels associated with traumatic injuries. So if you see patients who are in motor vehicle crashes, motor vehicle accidents, or they injure themselves on the job, in industrial, they, I don't know, lose some of their fingers when they're using something, cutting a saw or something, and they have elevated triglyceride levels, they may develop acute pancreatitis, believe it or not, because of those traumatic injuries. And then even, of course, any trauma to the abdomen, definitely. You want to be on the lookout for pancreatitis for these patients. Signs, symptoms, physical exam, depends on the severity of condition. Usually mild to severe pain in epigastric area or diffuse. There's diffuse abdominal discomfort. They may have fever, tachycardia, hypotension, and even hypoxemia if it's severe enough, where it's really acute. Your diagnostic testing, of course, your pancreatic enzymes, your lipase, amylase. They usually do abdominal x-rays or CT scans to see what's going on. And then usually it's aggressive IV fluid resuscitation, pain medications, and NPO status. Because the pancreas is so inflamed and has so much, as we all know from the anatomy and physiology we just went through, they have to make sure they get the pancreas back to normal so it maintains its functions within the GI system. And that's why usually they keep them NPO, and they're given like IV fluids at like 250 an hour. So they're really pouring fluids in there to help calm that inflammation of the pancreas. Your AHA coding clinic second quarter 2023, page 12 says, when both cholecystitis and gallstone pancreatitis are responsible for the inpatient admission, either condition can be sequenced as the principal diagnosis. Sometimes patients come in and they got an acute cholecystitis going on, but then when they're doing all the scanning, the imaging, they're like, oh no, they got a gallstone pancreatitis. So you can put the cholecystitis or your gallstone pancreatitis as the PDX. Another coding clinic from first quarter 2020, page 9 states that alcoholic pancreatitis is not classified as an alcohol-induced disorder. So documentation of alcoholic pancreatitis due to alcohol dependence is reported with K85.20, alcohol-induced acute pancreatitis without necrosis and infection. And then you also code your F10.20, alcohol dependence uncomplicated. So you can use two codes on these guys. I see a lot of docs writing alcohol-induced disorder, whether it's pancreatitis or they may attribute it to something else too. I can't think of the other diagnosis I saw. And it's like coding clinic says, no, you can code both because alcoholic pancreatitis is not an alcohol-induced disorder based on the coding rules and coding guidelines. So you can code your alcohol-induced acute pancreatitis as well as your alcohol dependence separately. Okay. And this alcoholism. Fortunately, I see a lot of this, whatever organization I'm working. Provider terms, alcohol use disorder. That's one of the newer terms that came out and newer codes for us from a CDI coding perspective. Alcohol dependence and alcohol abuse. Your DSM-5 criteria, I put this little table in. I thought it was a nice little helpful cheat sheet, so to speak, about substance use disorder. And it does give you the severities. And substance use, of course, disorder, that could be alcohol or it could be any drug, like your cocaine or your methamphetamine use disorder. Okay. And it gives you the criteria, which is nice. I thought it was just a little helpful table to share.
What does the DSM mean?
It's diagnostic and statistic manual mental disorders. It's diagnostic statistic manual. DSM.
Oh, no, I see it down.
It's on the bottom. I just read it. And this is the fifth edition, yeah. DSM, used for your mental health, your behavioral health units, they use the DSM, manual for coding and whatnot for diagnosing their patients with mental health illnesses. And of course, mental health illnesses include, right, your alcohol dependence, your drug dependence, not just your other psychiatric diagnosis, like your schizophrenia, your bipolar, manic depressives, or your major depressive disorders, so they include this as well. And the diagnostic criteria, they use this table as well as your blood alcohol level and your urine tox screens, right? They're coming in and they're going to do a drug screen on the patient, especially if they were in a motor vehicle accident. They want to see if their blood alcohol levels elevated, or were they ingesting anything else. Unfortunately, I just reviewed a record this past week with the contract company I'm working with, and the guy was in a motorcycle accident, but his tox screen came back positive for fentanyl. His blood alcohol level was up. He had cocaine in there, and there was opiates and something else. And I was like, yeah, you're lucky he didn't die. Definitely had a lot of fractures, nothing open, but, so it's interesting to see, unfortunately, that, all these tox screens are really important, especially for the providers if they're going to do surgery on these patients.
And it's getting worse. There's more and more abuse of all of it. It seems like
I'm telling you, it's getting worse throughout the country. Yeah. Lorna, do you see a lot of alcohol or drug abuse in Georgia, in your area where you work? I don't know if she heard me. Lorna, you there?
She's muted.
Yeah, she's muted, I think.
Yes, I'm here.
Okay. No, that's okay.
No, I don't come across a lot. Not that I just had one actually, but not a lot yet. But of course, I've just been in this 2 months. But my working in oncology, no, not as much. No.
Yeah.
And you would think you would see it in that area, actually. People would be trying to find other ways to help their pain and such.
Right.
Okay. Well, thanks for sharing.
Yeah,
it's
Georgia.
I was going to say, yeah. And it's different. And, I worked, a contract company I worked with last year was in Florida. And of course, you had all the snowbirds going down south, right? From upstate. From northern, your New England states and whatnot, or, your Midwest states going down to the sunnier weather, like we get snowbirds here from Montana and British Columbia, Alberta, Canada. They all come down to Arizona in the area where my husband and I live now. So, it's interesting to see the different populations, in the different countries, even throughout our country in America and US. what you see and what's out there in healthcare too. So, all
And
right.
I don't know if you know that Narcan is over the counter. I didn't know that.
They are given Narcan for patients who have a prescription for one of the pain meds that can, like a fentanyl. If you get the
No.
fentanyl, you get the type of fentanyl pill for pain control or opiates, they're going to give you Narcan.
Yeah, but like my niece, they went to New York, and they say it's just right there over the counter. You just have to ask them to get it for you. So it's not like they have a prescription for it. But I didn't know that.
Oh,
She
over
she
the
even
counter,
took the
like,
picture.
oh,
Yeah, I know, because of so
Yeah, it's
many
over the
overdoses,
counter
I guess.
here too, and they give you like a
Mm-hmm.
little education on it if when you get it.
Mm-hmm. Yeah, because
well,
of so many
hopefully it's not a,
overdoses. Hmm?
I
I'm
was going
sorry.
to say, hopefully it's not a high dose or anything. It's very minimal.
Probably, yeah, probably just a minimal, just to wake whoever has a
Well,
cold.
it's given to those, like you said, with certain pain medication that are on those medications, but it's also over the counter, and that like those who might, I don't know quite what the criteria is, but if you're around or exposed to those that are on those kind of meds, that as a second person around, you can get it. And then my understanding is it was going to go to being available to everybody. Like I wanted to go get it just in case I ever came across somebody
Yeah, yeah.
that,
It's a
but
good
at the same
idea.
time, do I want that responsibility for it? So
Uh-huh.
I haven't done it.
That's
Well,
true.
that's the other
Yeah,
piece, right?
yeah,
Yeah,
yeah.
that's the other piece of the
That's
pie. Well, that's
yeah.
interesting.
It
Yeah.
is. It was interesting for me when she said that. I said, "Oh, really?"
Wow. Yeah. Well, I tell you, I don't know. Definitely interesting. Well, treatment for your alcoholism, usually it's, of course, it's trained healthcare professionals, your psychiatrists, any behavioral health nurses, um, that are out there to help these patients. Medications for withdrawal symptoms, of course, and then serial labs as noted above. And then Coding Clinic first quarter in 2022, pages 24 and 25 said, do not assume a relationship between alcohol abuse and or dependence with anxiety. The relationship between alcohol use and the disorder must be documented by the provider to report an alcohol-induced disorder. And of course, what's that? A query opportunity for us. So, you can't say that it's a causal relationship. Like certain diagnoses are automatically linked. And I think the biggest one that I comes to mind all the time is your diabetes now. We don't have to send a query to the provider to get the diabetes linked to neuropathy or what's the other ones that we
CKD,
have? Yeah.
CKD,
CKD,
or
they're automatically a link now and assumed.
hypertension. Yeah.
Yeah. So we don't have to worry about sending queries like we did way back when Christy and I started years ago. So that's something that the coding clinic and the coding rules updated us. And I think they did that back in 2017 or 2018. They just automatically linked them for us. So we don't have to bother the provider on little stuff like that. Okay. Coagulopathy. This is another one. Provider terms, you may see coagulopathy, DIC, liver disease coagulopathy, even hemophilia A and B, and hyperfibrinolysis. Diagnostic workup, of course, your coag panel, right? Your PTINR and your APTT. Signs and symptoms, usually bleeding. There's some type of bleeding going on for these patients. Treatment depends on the diagnosis. Okay. Are they on anticoagulant medication? If they are, they're going to discontinue it. They may administer vitamin K or fresh flows in plasma or even IV clotting factor to these patients. On Coding Clinic, second quarter 2021, page 8 says your secondary hypercoagulable state are acquired disorders due to multifactorial mechanisms. So patients with atrial fib on chronic anticoagulation therapy may demonstrate an acquired hypercoagulable state. So the provider must specifically document that there is a secondary hypercoagulable state to atrial fib. And then it can be reported as D68.98, other thrombophilia, to capture that secondary hypercoagulable state. Okay? So if the provider doesn't link it, guess what we do? We send a query and say, is this going on? There's also another one, hemorrhagic disorder due to external anticoagulation medication or treatment. So that's another big piece of the pie too. So you always want to make sure you clarify what exactly the coagulopathy is. Link it to that underlying etiology, because then it'll give you can capture a CC with that link. Coagulopathy unspecified. Usually I think other coagulation defects, they can be a CC as well. Usually I try linking it though. And then just a note, coagulation defects are exclusions to PSI 9, perioperative hemorrhage. And D69.6, thrombocytopenia unspecified, also provides an exclusion. So there are different, as we all know, and Lorna, you're going to be learning this too. PSIs are your patient safety indicators. And there are a list of PSIs, and one of them is your peri-op hemorrhage. So if they're in surgery and then they start bleeding out, but they're on medications, or they have some type of liver disease coagulopathy or something else, they're in a hypocoagulable state because of medications they're taking, or they have other clotting factor dyscrasias. That won't be reported under your PSI 9, which is your peri-op hemorrhage.
Okay.
Unfortunately, there's a lot of different patient safety indicators out there today, that CDI, that we try to be on top of. But when you're just reviewing records from a CDI point of view to get diagnosis specificity listed out, for all the diagnoses that are listed in that record that you're reviewing, that chart. There are other departments within CDI or within revenue cycle or HIM or in your quality department that specifically look at PSIs. Okay. The current company I work for now, they do have a quality team that looks at PSIs and HACs, which are your hospital-acquired conditions. They do a review of those, and sometimes they'll question the provider. They don't do those reviews until post-discharge, though, okay? They need that data once they're discharged, like coders need that, all the diagnoses listed out so they can send the final coding out, right, to the insurance through the business office. So usually we don't get involved with PSI so much. HACs we're going to monitor though. Sometimes if you come across a PSI, it will probably be followed up upon discharge by quality department or another group, solely to review PSIs for that particular hospital.
Also on coagulopathy, what would be the clinical indicator to query this diagnosis?
Well, if you have an unspecified, but you have some of the other diagnoses in there, you do want to see if you can link them, because that's important.
Right.
It's important to not have a specified if you can ever specify further.
That's right. Yes. And also, like if it's not documented, right, you look at the INR, right? If it's elevated, then you're gonna think, is this coagulopathy? But I was told that to be able to be accurate, there should always be bleeding if you want to ask for coagulopathy. So if, for example, the INR is elevated, you want to make sure there's also like bleeding that's documented. So, and another thing with INR, you want to make sure that the patient is not on anticoagulant, or is it for atrial fib, right?
Right.
Because it will be, they have to reach a specific INR, and it could be like much elevated than the normal, but the doctor needs to achieve the certain INR to adjust their like the Coumadin, right? So want to make sure when you see an elevated INR, is it because the patient is on Coumadin, or the patient has AFib that the doctor is adjusting the INR? But if there's no Coumadin and there's no AFib, then the INR is elevated, then you think about, is this patient having coagulopathy, especially if the patient has bleeding. So that's just a query opportunity.
Right. Okay. All right. And this is just some of the, I figured some of the common anticoagulation meds that you see with the reversal. This is a nice little,
Mm-hmm.
I found this to be
Yeah.
a nice little table. It's helpful from a CDI. Lorna, this will probably definitely help you too as a new CDI. It'll give you some idea what that you may see in the records for any coagulopathy going on for patients that are admitted.
Got you. Okay, I screenshot it.
Yeah, there you go. It's always
that's a
helpful to
great
have these
table.
little tables. I used to have tons of Post-it notes when I first started, all over my cubicle when we were in the hospital at that time.
Oh, yes.
I still have Post-it notes all over.
Yeah, that's it.
It
I have Anne-Marie
helps.
Post-it notes in my cubicle.
Yeah. Okay. All right. Diabetes. This is really another big one that you're going to see a lot of patients with, unfortunately. So the provider terms, you may see type 1 diabetes or type 1.5 diabetes, but they also may document LADA, LADA, and this is your type 1.5 diabetes. It's latent autoimmune diabetes in adults. Of course, your type 2 diabetes, secondary diabetes, drug-induced diabetes, or gestational diabetes. Gestational, of course, for your pregnant women. Secondary diabetes could be associated with another diagnosis. Like my husband has secondary diagnosis because he had a lymphoma. Okay. Drug-induced diabetes, that could be related to chemotherapy, to radiation therapy. It could be related to other medications patients are on for other chronic
Steroids.
conditions. Yeah. So
I'm a steroid-induced diabetic.
steroid-induced
yeah.
diabetes. Yep. Drug-induced. Definitely steroids play a big role in that. And then, of course, there's acute diabetic complications. So that's your diabetic hyperosmolar hyperglycemic state, or HHS. We like a lot of abbreviations in CDI, Lorna. You will see that. Your diabetic ketoacidosis, or DKA, and then your euglycemic diabetic ketoacidosis. These are all emergent in nature. And I did see one euglycemic diabetes DKA. As a matter of fact, I reviewed that record last week. So it can happen. And definitely they're starting insulin drips, or they're taking care of that patient very quickly and doing hourly checks, sugar checks. Sometimes they even do every 30-minute sugar checks at the bedside, and they're usually in ICU to keep an eye on them because they can develop other problems. Signs and symptoms in your exam, usually weakness, fatigue. They may have mental status changes too. They may be somnolent, altered mental status, confusion, disorientation. You may see urinary frequency, polyuria, and polydipsia, of course, are cardinal signs for any diabetic patient if they're new onset. Your diagnostic criteria, of course, any fasting blood glucose levels. They'll do random blood glucose levels. They'll also draw an HbA1c, right? Because that'll give you an idea on how severe their diabetes is. Especially if they're newly diagnosed, they're a new onset diabetic, and their doctors are saying they're a type 2. They're going to draw a hemoglobin A1c to see what level it is, and usually if it's consistently over 6 or higher, they are considered a diabetic. And one patient I had, they had a blood sugar of 520. They were somnolent. They were almost comatose because it's severe, and their A1C was like 12.6 or something. And I was like, oh my God, this guy's going to go into a coma. And he was really sick. And it was and a middle-aged guy. It wasn't, no 70, 60-year-old, but this was like, I think mid 40s maybe. And he was really sick. I mean, I thought they were, even the providers kept writing guarded condition. I mean, they were just on every note because they didn't think that this guy was going to wake up, because he did end up going into a coma. And they were trying everything. They even put him on the respirator, and really, it took a few days, but he started moving his fingers, I think what the nurses were saying, and he started blinking his eyes. They were trying to wake him up, but he was severe. I mean, he was in a coma. He had coma with his new onset of DKA. I mean, so yeah, but he was lucky he was, he's still alive.
And I've seen like a lot coming in. I don't know if you have as well, that with the people that are not getting routine medical care, and then they're coming in with undiagnosed diabetes. Like you said, their levels are in the 12, and they might not always be in DKA, but they're lucky they're not in DKA because of
right. Absolutely.
Condition.
Yeah, absolutely. So, and of course, your treatment is going to depend on the underlying etiology. And like I said, they could be doing insulin drips, IV fluid hydration. They give a lot of that too. And then, of course, your serial blood glucose levels. So, Coding Clinic, second quarter 2023, pages 8 to 10, say assign codes E11.65, type 2 diabetes with hyperglycemia, and T45.1X5A, adverse effect of anti-neoplastic immunosuppressive drugs, initial encounter, for documentation of hypoglycemia secondary to autoimmune diabetes mellitus caused by initiation of immunotherapy medication in patients with pre-existing type 2 diabetes. So if a patient already has type 2 diabetes and they're starting immunotherapy for whatever reason, whatever their diagnosis is, then you're going to assign these two codes, because of course, your immunotherapy is being prescribed and being, taken accordingly based on the treatment plan of the provider. Coding Clinic first quarter 2022, page 28 states hyperglycemia is inherent to code E11.00. Type 2 diabetes mellitus with hyperosmolarity without non-ketotic hyperglycemia, hyperosmolar coma. It should not be coded separately in such situations. So if you have a type 2 diabetes with HNK, HHC, and you'll see all that, or, listed by the providers, you only code the E11.00, and you don't code the E11.65 type 2 diabetes with hyperglycemia, as noted above. Okay. And like I said, the 3F encoder will give you exclude notes within the encoder for your nosology edits. They will tell you, no, you can't have this code with that code. All right. All right, now let's talk about quality documentation challenges. So as you can see, documentation affects a lot of pieces of the pie, which is all part of the value-based purchasing program for hospitals as well as your physicians. So you have your severity of illness and risk of mortality data points. That's your SOI and ROM that we see on the DRG assignment in 3M. They're also part of RAC audits and your compliance. POA is a big piece of the pie for CDSs because that's your present on admission indicator. It also provides profiles for your hospital and physicians. So it's not just physicians getting some quality incentive through the value-based purchasing programs. Also, the hospitals are involved as well. And then, of course, your medical necessity and length of stay. That's your where case management is involved. Patients are admitted to the hospital if they have a commercial payer like Blue Cross or Aetna or United Health Group. They have to fill in. Case management sends information to that payer, commercial payer, to say why they need to be admitted to the inpatient hospital. And that's your medical necessity information. And then your length of stay also is a piece of your DRG assignment with the SOI and ROM data. And of course, bottom line is your reimbursement, right? It's going to affect all of that. So what I tell the documentation challenges that we see, if it's not documented, it didn't happen, right? Just like nursing. If it's not documented, it didn't happen, didn't occur. So there's a gap between the physician documentation and the coding language. And of course, our providers take the shortcuts, right, with documentation. They do a copy paste, or they can pull data from one progress note, yesterday's progress note to today's, and they don't update anything. And that's the copy paste phenomena that we see a lot of today with the electronic records. The impact of documentation, for specific diagnoses is not well known in many healthcare establishments, whether it's inpatient or outpatient. There's CDI programs in the outpatient side now they're going to be reviewing those diagnoses. And then documentation practices aren't really taught in the medical residency programs. Some schools have initiated coding classes for some of the docs, in some of the residency programs, and some of the fellows too. I know they're taking some coding classes in their fellowship, which is helpful, especially if they're going to be, they're going to have their own practice, outside the hospital. So the docs really need to understand that, and that's why they hire coders to help them along. Okay. And then the high quality documentation elements are all listed here, legible. You want to understand the documentation. It's reliable, it's trustworthy and safe. It's precise, it's accurate and exact. It's complete. Documentation is thorough, meaning it's documented throughout the medical record and including in the discharge summary, all these diagnoses. It's consistent. There's no contraindications in the documentation. The one thing I always see cardiologists is saying, no, it's a type 2 MI. And then the attending is writing, no, it's only demand ischemia. So you have to clarify that because that's contradiction in the documentation. It's clear. There's no ambiguity within the documentation, and it's timely. It's completed within the time frame set by the hospital bylaws. Now, hospital bylaws are different in every hospital. Some hospitals, like for the discharge summary, some hospitals give their providers up to 7 days to complete the discharge summary. Other hospitals will give their providers up to 2 weeks to complete a discharge summary. So you definitely want to keep an eye on that. And if you're under your HIM department, you definitely want to find out what the hospital bylaws are when it comes to certain documentation. I know with patients who are admitted for a hospital, for a procedure, they're like for a cabbage or something, they have to have an H&P done within 30 days of that procedure. If the H&P is outside that 30-day window, then they have to create another H&P for that patient. Okay. So you definitely want to clarify certain timeframes when it comes to like your H&Ps When do they have to be done for a patient who is admitted into the hospital? Is it within 24 hours? Is it within 48 hours? So that's why it's important to know timeframes within the hospital that you're working in.
And watch your draft notes.
And watch your draft notes. That's right. Okay. Let's just go through a little bit about, got a query about queries, right? 2022 AHIMA ACDIS Query Practice Brief Update. They got together and says, okay, this is what we're going to do. We're going to put it all together for us. They finally are one big company now, which is nice. Okay. So the reasons why they updated everything is to support documentation of medical diagnoses or conditions that are clinically evident and meet UHDDS requirements, but without the corresponding diagnoses or conditions stated. Resolving any conflicting documentation between the attending provider or other treating providers, whether it's diagnostic or procedural. Clarify the reason for the inpatient admission. Seek clarification when it appears a documented diagnosis is not clinically supported. And that's where we send the clinical validity or clinical validation queries. We want to establish a diagnostic cause and effect relationship between medical conditions. We want to establish the acuity or specificity of a documented diagnosis to avoid reporting or a default or unspecified code. We never want an unspecified code when we're reviewing the record. That's what we're in charge for, to make sure we get specificity for all the diagnoses listed. Sometimes you may not get everything, like your hypothyroidism, your chronic conditions, hyperlipidemia, even your hypertension. It may be unspecified and that's fine, but they're getting treatment for it, so we can list it as a secondary diagnosis. Establish the relevance of a condition documented as history of to determine the condition is active or not resolved. To support appropriate POA indicator assignment. Clarify if a diagnosis is ruled in or out, and to clarify the objective and extent of a procedure. And that's really important too. Sometimes we may have to send queries on surgeries to the surgeon who performed the procedure.
Now you'll love this. I've had two different diagnoses lately that I've queried on because they weren't documented in the beginning of all the notes. And then the documentation implied that they developed. And this was for respiratory failure and for heart failure. And then they would document acute on chronic, implying that it wasn't present on admission, implying that. So I did a query to clarify, and they're saying no, and yet it's an acute on chronic.
Yeah.
On both of those. I'm like, okay. I mean, I can't go against the physician, but I'm like,
right.
Okay.
So that's the other piece of the pie too, they're the ones, I think a lot of providers do not know what present on admission indicator means, to be honest. Because if they're coming in with, they have fluid overload or whatever, they got an exacerbation going on at the get-go, but they're not documented until 2 or 3 days into the stay, right? After 48 hours is what we look for,
right.
For not present on admission status. But you know what? You go according to what they're writing because they're the provider, and that's the thing. They're the expert. So sometimes it's difficult to figure that out too, based on what they're writing.
It's really hard to code an acute on chronic anything POA no.
I know, right?
Like there's a problem with that.
I know. So some of the compliant query practice brief also states that, you can use multiple choice answers. Yes and no answers usually used for POA status, and that's what I usually send. Clinical indicators, your 3-legged stools to support the query answer options. The quality of your clinical indicators is more important than the quantity of your clinical indicators used. And then you provide specific date, time, and provider name to all documentation listed within the query clinical indicators. Usually the provider name, I don't write the provider name like Dr. Hook. I won't write Dr. Hook in there, but I'll write down, 4, 10, 24, 1400 cardiology consultant notes. You know what I mean? But check according to how your query policies are too at your facility, because it's always helpful to know the way they want it set up. Clinical evidence within the medical record should be as accurate as possible when performing a clinical validation query for a specific diagnosis. And then treatment and clinical criteria or diagnosis from a prior encounter may be used, but again, it's based on your facility policy. Like, say you're trying to figure out what type the heart failure is, say they come in with the CHF exacerbation. They're not giving you the type, whether it's systolic, diastolic, combined, mid-range, whatever. So you definitely need an echo, and they didn't do an echo during this admission, but they did one 6 months ago when the patient was admitted for a heart failure exacerbation. So look at your facility policy. I know there's one company I worked with last year. We can go back a year or 2 years even to get an echo, which I think is just too far out, to be honest, because your echo, everything changes, but they said you can go up to a year on one of them. So,
wow.
Yeah, that's a little too long to me, to be honest. Anyway. And then when to query. Stop. So to support documentation of medical diagnoses or conditions that are clinically evident, to determine if a diagnosis is ruled in or ruled out, to clarify the objective and or extent of a procedure. Usually, sometimes with the op reports, you may have to clarify the root operation. Is it an excision, a non-excision debridement, or an excisional debridement? So sometimes you may be sending queries for procedures. If you're unsure, just check with your team when sending a procedure query. Also with a complication query, these can be a little tricky. Because the surgeons, you don't want to ding the surgeons on a procedure with a complication if it didn't occur or it's inherent to that procedure. So you always want to just make sure you got everything, your ducks in a row when you're sending a procedure query or a complication related to medical care or procedure to the providers. Clarify a diagnosis on an ancillary note that has been signed by a provider. Usually ancillary notes, I look for your pressure injuries, that's your wound care, your nutrition with the BMI, and they might have written malnutrition on a patient. So you definitely want to clarify and confirm that specific diagnosis with the provider. To support appropriate POA indicator assignment, to establish the relevance of a condition documented as history of, to determine if the condition is active. If they come in, they have a history of PE, but they're still on anticoagulation. So is it a chronic PE, or did they develop a new one, an acute? Okay. So you definitely want to keep an eye on that. Establish clinically supported acuity or specificity of a documented diagnosis to avoid reporting a default or unspecified code, like we said earlier, as well as cause and effect relationship between medical conditions, and to confirm a diagnosis, from another independent practitioner. But they're not taking care of that patient. That's like your path report, your radiology reports. They're an indirect patient care provider. So you cannot just take stuff off those path reports or those x-rays, the diagnoses. The treating providers, the attending, any consults on the case must be documenting that information from those finding reports, those imagings. Clinical validations, another one we always send. Clarify the reason for inpatient-outpatient encounter, and resolve conflicting diagnostic or procedure documentation between providers.
And the
So,
inpatient and the outpatient is very helpful for the case managers. So
right. Okay, and when not to query. Queries are not necessary for every discrepancy or unaddressed documentation and issue in accordance with an organization's policy and procedure. Circumstances may include lack of business need, risk of query fatigue, I see that a lot, or does not add to the clarity of the clinical picture. So you don't want to query a provider if you cannot offer clarification-based information on the present health record documentation. I think that's really important, that you don't query everything. In one of the companies I worked for last year, they queried everything. These doctors, I'm telling you, they got query weary, query fatigue because of everything that we did. And they queried every little thing, trust me. But the providers started pushing back too. On it. So they were like, okay, well, let's just look at this from quality perspective and financial impact. And then they started slowing down a little bit with sending all these little queries to the docs. And queries should only be generated when the clinical data, present or relative historical data, like a prior echo, fully supports the answer choices. I had a coder ask me to query for ABLA on a patient. I said, the patient doesn't have ABLA. The patient has anemia due to neoplastic disease, cancer, and they have severe iron deficiency anemia. So I reached out to my team, and says, listen, they want me to send this, and there's no clinical indicators to support that diagnosis. So it was really interesting to see that the team, my education team and my supervisor agreed with me on that, and she asked for elevated platelets for thrombocytosis diagnosis. And I was like, well, they kept doing monitoring. And then the supervisor says, no, it doesn't meet the UHDDS criteria to report a secondary diagnosis. So he didn't consider the treatment of serial CVCs monitoring a treatment for that particular patient. So I said, okay, I just doing what they want me to do. So
I had one recently like that for ABLA too, where they were linking the anemia to both the kidney disease and the malignancy. And they had several blood products actually and a drop, but there was no bleeding. And the coder asked me about ABLA, and I'm like, no, it's clearly linked to the kidney disease and to the malignancy, and I'm not querying for ABLA. There's no bleeding. There's no
and that's the key. Yep.
And that's the key word is the bleeding.
Right. To get ABLA in there.
And the patient has had frequent episodes of needing blood transfusion. So there's a history there as well, not just a sudden issue that requires it, that you might think maybe there's bleeding not known, but there was no, the testing didn't support it either.
Right.
Yeah.
You definitely need a source for ABLA, period. Whether it's surgery or GI bleeding of some sort, you got to have a source.
Yeah. Hematoma and treatment.
And
yeah.
treatment.
Uh-huh. Yep. That one doctor that keeps documenting it, and there's no treatment. Oh my God. And there's no drop in H&H. I'm like, oh, you're giving me a
yeah. Well, the coder wanted it because the patient had a colon resection, of course, because of the malignancy that they found. That's why she had the bleeding, because of the malignancy. But they never did any blood transfusion, and the EBL for the surgery was like 100 cc's. I was like, that doesn't even meet the criteria that you guys just set up. It has to be, for me to send an ABLA query, they even created a policy for ABLA, saying that it has to be, the EBL has to be at least over 300 cc's or 350 to send that query. So, all right, case studies. Christy is up.
Yeah, it's a 78-year-old male admitted for acute anemia. Past medical history includes lung cancer, status post resection of the left upper lobe, mixed hyperlipidemia, hypothyroidism. Patient did note some melena over the past 2 days. The workup revealed the following: HNH of 6.8 and 19.3. Patient's baseline is around 10.2 and 31. LFTs within normal limit. CA19-9 tumor marker elevated at 68 and CEA elevated 5.6. CTAP suspicious lesion in the descending column concerning for malignancy. The treatment given is blood transfusion 1 unit with post-transfusion HNH and every 8 hours thereafter. GI consultation for an endoscopy procedure. Attending provider H&P indicates melena with acute anemia, rule out GI malignancy. GI consulted and ordered transfuse 1 unit of RBC with serial HNH every 8 hours. GI consult indicates the following: acute anemia with melena for the past several days, tumor markers elevated, CT notes suspicious lesion in the descending colon, will need colonoscopy procedure to confirm malignancy. Colonoscopy procedure finding: friable tumor noted in the descending colon, biopsy sent to pathology, cauterized bleeding of mass, recommended surgical oncology. So what is our primary diagnosis here?
The melena for right now.
Yeah, melena with acute anemia, right? Because the attending
Yeah.
provider did for melena with acute
Because
anemia.
we don't know
So
for sure yet if they have cancer because we don't have path results yet.
that's right. Yeah. So that's why it's important for the follow-up review because, like we said in previous class, that the primary diagnosis can change depending on the result of the follow-up notes and exam. Okay,
And you
so
could
that's our.
query for obla because the melena
Mhm,
and the
that's right.
hemoglobin of 6.8 is acute,
Very low.
and
Yeah.
you receive blood. So you could query
Mhm.
you couldn't query to link it yet with cancer, but you could just do it as a general.
Yes, a general, especially if the patient has melena and also has the HNH. So you have the clinical indicators there.
And
You
treatment.
document the melena and then anemia, and then you could put the HNH there, as well as the treatment of blood transfusion. So very good. So that's your possible query: is the acute blood loss anemia. Anything
And
else?
most likely, if it's cancer, it's a new thing, and anemia might not even be related to that yet because it's a new
That's right.
cancer.
Yeah. Unless they specifically link it, towards the end, like the last progress notes, they will link the anemia due to cancer. But for now, no, we don't have that linkage yet, and they're still just doing we don't have the biopsy yet, right?
Yeah.
It's still sent to pathology, so we cannot assume. So, anything else?
No, I'm not seeing anything else. Feel free to tell me what I'm missing.
Well, like you said, it could be cancer, right? So we need to follow up the biopsy report. And like some facilities, like the patient may be discharged already before, the biopsy report
Oh, yeah, you want to
comes
do
back.
a pathology query once you get the
Yeah,
results to
yeah.
confirm that.
Mm-hmm. Yeah, but sometimes, like I said, the patient's been discharged. So, like some facilities, the CDI not involved anymore post-discharge, but some facilities they are still involved. So just follow up the pathology report and see whether there
Yeah,
is
my coders always give
documentation.
me a heads up if there's path, when they do final coding, because maybe the patient my last review and their discharge is a few days
Mhm.
apart, and the doctor didn't have the path results then, but now they're back when they final code. So
That's right, especially with the elevated tumor markers
yeah,
and the CEA as well as the CT report. So, and the colonoscopy procedure only says variable tumor. So we don't know yet until we get the path report. So we just need to follow it up, and also recommend surgical oncology consult. Just follow up with the surgery, the surgeon, oncology surgeon, documented, and hopefully, it's most of the time they're already, before discharge, they'll see the patient. And then what we could do is see what the diagnosis he writes, and then, ask the doctor if he agrees with that diagnosis. So it could be included in the final DRG coding. So, but otherwise, for now, it's just the ABLA.
Right.
Mhm.
All right.
Anything more, Anne-Marie?
Nope,
Oh,
I
there
think
it is.
that's it because,
Mhm.
yeah, the path, yeah, definitely. Company I work for, the coders can't send queries. There are some organizations that the coders will send queries.
Mhm.
This company I work for now, we send the queries post-discharge. So, and I did send a path report for a patient yesterday. So,
Yeah, same
so
with
but this
my
is,
facility.
yeah,
Mhm.
it does vary. Yep, absolutely. And this is just a sample query for the anemia, you know, short and sweet.
Yeah.
And some of the trigger words that we look for. So when the docs are writing GI bleed, hematuria, or surgery with a high EBL, that could be a possible query for your ABLA or acute post-hemorrhagic anemia. It's the same code, D62. Okay.
Okay, case number 2 is 52-year-old female direct admit to telemetry unit, inpatient hospital for polydipsia, polyuria, and somnolence. Workup revealed blood glucose of 525, hemoglobin A1C is 9.2, serum sodium of 156, HNH 18.5 and 42.2, beta hydroxybutyrate of 3.7, and urinalysis provides or positive for ketones and glucose. The attending provider H&P indicates severe dehydration, type 1 diabetes with hyperglycemia, IV fluids, serial blood glucose levels, sliding scale coverage, and endocrine consultation were ordered. Endocrinology consultation notes severe dehydration with DKA, aggressive IV fluids, start insulin drip, DC sliding scale coverage at this time, transfer to ICU, and glucose levels every 2 hours. So, what is our primary diagnosis here?
Well, I would want to query
Yes.
because we kind of have different, a little bit of conflicting documentation, but I was trying to remember back to our rule that Anne-Marie had gone over. I mean, we could take it to the type 1 DM with the DKA, but I'd like to see the attending also say the DKA.
That's
I
right.
think there
Yes.
was an association, but I can't remember if you could just go ahead and code it without having to query.
I think because the attending provider documented only type 1 DM with hyperglycemia, but DKA is a more severe, right, diagnosis because it's ketoacidosis already. So I would clarify that. I will
I
ask,
would too, because
per
also the endocrinologist isn't specifying what type. So I'd
yes,
like to just see them be on the same page.
that's right. So you wanna, clarify per endocrinology, notes patient has DKA, so you want him to document that too.
But was there an association thing, Anne-Marie, that you said, or am I incorrect on that?
Well, that's for the manifestation codes, right?
Okay.
For the other complications associated with diabetes.
Yeah. So then personally,
Yeah.
I would query to get the specificity documented by the
That's right.
DKA documented by the attending. That's what I would want.
Mhm. That's right. And you would like to see that DKA would be the primary diagnosis
Yeah,
instead
would
of
be,
severe
yeah.
instead of severe dehydration, although the patient has dehydration with a sodium 156. So anything more?
Wait, what was 156? Oh, the
Sodium.
the sodium was high because usually on those high glucose you get a low sodium, which is a pseudo hyponatremia.
Yeah. Yeah.
Yeah, so I'd want to get the hyponatremia documented too, because I don't see that.
Mm-hmm.
But you're introducing, so that's a tricky.
It is. We could just document. It depends on what you put on your choices. If you put
Yeah, I
your
always kind of
hyperglycemia.
try to bring some of those little things in to see that maybe they'll see it and they'll
Yeah.
recall that they should
Mm-hmm.
document that without me having to query sometimes.
That's right. Yes. Yeah. It's like sometimes you said don't introduce the diagnosis, but if you have choices like hyperglycemia, what do you call this other one? It's unable to determine or others. So, yeah. So I don't think it would be like introducing the diagnosis as long as you give them choices. So I would query that, especially if they give IV fluids. I don't know how fast. It doesn't say here. So, and I would put that in my treatment, the IV fluids.
Yeah, it doesn't say if they gave the some
Yeah,
of the
like
meds they
is,
give
is
too
it
with the
only
bag and all that. So
yeah, is it only a TKO or 125 per hour? So you have to follow up how fast they wanted the IV fluids to compensate for that elevated sodium. Anything else?
not that I see.
Okay, so I'll just follow up for the somnolence. See, since there is electrolyte imbalance there, and you have the
I'll watch for
diabetes, just the
encephalopathy. Yeah.
encephalopathy. Yeah,
Yeah.
just follow it up
Right.
and see. Right now, we only have that documentation, but we don't have enough clinical indicators to really clarify that. So, like we have the DKA. We want to follow up the hypernatremia. We want to follow up the somnolence equals encephalopathy. So those are the query opportunities.
Yeah.
Okay.
All right. And this is just with a conflicting documentation,
Mm-hmm, mm-hmm.
Yeah. Yeah, because they're documenting not too different, but not the same.
The same,
Right.
yes. Uh-huh, uh-huh. One
Attending
is simple,
saying
is
with
one more
hyperglycemia,
complicated.
endocrine is saying DKA.
Mm-hmm, mm-hmm.
Yeah.
Yes. Mm-hmm.
And I would have just added the sodium just to see if I could trigger their brain.
That's
Yeah,
right.
there you
Yes. I know. Yeah. Yeah.
Like, can you just
Mm-hmm.
kind of look at this and then go from there?
Yeah. Like how high is the sodium power? Because sometimes when they see it, they will like in your query, probably I better clarify this before they ask me another question.
Yeah, there you go.
So,
That's right.
yeah. Mm-hmm.
Especially
Okay.
since it's a hypernatremia versus a hyponatremia that usually comes with those DKAs.
Uh-huh. That's right. Yes. Is it, what's going on, right?
Right. Very good. Okay. And then this is the query opportunity, just gives you the clinical indicators on, when we're looking for your common complications. Okay.
Things
Neuropathy, gastroparesis, CKD, or glomerulosclerosis.
Glomerulosclerosis.
Glomerulosclerosis. Okay, a PVD, PAD, things like that. Even your hyperlipidemia too. Sometimes the docs, some facilities will say, "Oh, I want you to pose the question to the doc if the diabetes is related to the hyperlipidemia." Some facilities want you to still, send a query on that. Other facilities want you not to. You don't worry about it. Skin ulcers, if they're on the foot and the toe, then they're usually linked. Okay.
Mhm, mhm.
But other skin ulcers in other parts, like your decubitus ulcers or things like that, you have to query those in other specific locations. Only the foot and toe ulcers, diabetic foot and toe ulcers, are automatically linked.
Mhm.
Okay, just remember that.
Yeah, and yeah, just remember that it's an HCC, so it's a biggie. Like at Kaiser, it's always the doctor always documents those diabetes with complications. So
Yeah.
Yeah, our guys in Dallas are pretty good.
Yeah. All right. Case number 3.
Case number 3 is a 67-year-old male admitted with right upper quadrant pain, jaundice, and somnolence. Vital signs revealed the following: temp of 99.2, heart rate of 98, respiration of 24, BP of 112 over 58, past medical history significant for alcoholic liver cirrhosis, hypothyroidism, and mixed hyperlipidemia. Provider immediately intubated patient and placed on mechanical vent. Workup revealed LFTs. ALT AST is 435 over 354. Alkaline phos is 343. Total bilirubin is 7.6. Coagulation profile INR is 15. PT-INR is 15.6 and 7.8. Ammonia levels 109. ABG's pH of 7.21, PO2 58, PCO2 of 55, SPO2 of 83% on room air, lactic level 5.4. Attending provider diagnosed patient with liver failure with cirrhosis, somnolence, acute respiratory distress, hypercoagulable state, jaundice, GI and ICU consultants ordered. GI consult diagnosis is fulminant alcoholic liver failure, overall poor prognosis, continuous symptomatic management with lactulose by NG tube, NPO status and IV maintenance fluids, serial coag and LFT levels, mechanical ventilation management per intensivist. So what is our primary diagnosis here?
The liver failure.
The liver failure with cirrhosis, right? So, any query opportunities?
Your coagulopathy, for sure.
But there's no bleeding, right? But he already documented hypercoagulable state. And I don't
Oh,
see.
yes, he did. Okay, I see that.
Yeah.
Okay.
And jaundice is a CC, so I don't know if they remove it already, but he used to be a CC.
I think it goes to a CC. I had to use it like a couple weeks ago.
Yeah.
See, I see the ABG and I see the vent, but I would want because that it's clarifying the respiratory distress, but you have to be careful.
Yeah.
And I have more information, but you could definitely clarify and see if it's a respiratory failure or intubated because they were somnolent.
Yeah, especially if the patient has respiratory distress, and you have this ABG result. SPO2 is only 83%. So I think I'll be comfortable to ask for acute respiratory distress. Failure.
Yeah, I want to see the PF ratio and all that stuff too. But I mean, they're placed on a vent, so you either need to specify is it for airway protection or for respiratory failure with respiratory distress documented.
And some doctors will document for what do you call this?
Airway protection.
Airway protection. Yes. So that's right. You have you want to. If they did that already, I think I'm gonna follow it up after 3 days. If the patient is still intubated, I want to see how's the ABG, because if it's only airway protection, I would suppose that they would have weaned the patient.
Or your ABGs wouldn't get worse, because I also look at that.
Right. Yeah,
ABGs get worse, then why are they getting worse when they're on a vent?
That's right. That's true. Anything more?
And then possible encephalopathy.
Yeah, because the patient is somnolent, right? And also the ammonia level is quite high. It's 109. So
everything's high.
Yeah. Poor patient. So what else?
I'm not sure what else. And we got
I would ask for the,
failure. We need to specify the cirrhosis.
or we would need to specify the liver failure. Is it acute?
Yeah.
Is it,
Acute,
is it
subacute.
acute?
Is it
Yeah,
acute,
chronic, is it, or
subacute,
is it
and what's our
subacute?
cirrhosis
Yes.
source?
Yeah. Because I think, well, that is our
Although
primary
it says
diagnosis.
alcoholic liver failure in the GI consult. So
Yeah.
we don't need to specify the cirrhosis.
That's right, because it's
Just the
alcoholic
liver
liver
failure.
failure. Mm-hmm.
But he also says fulminant, which means a sudden and acute. Can we assume that correlation with that word?
Well, you can't put it in the encoder; it won't come up, right?
Right. That's like I say. You'd have to clarify.
Yeah, but I mean,
That's correct,
I
right.
see your point. I mean, if you query the doctor and they'll say, "I already document fulminant."
Yeah, and that's I just
It's
looked it
not
up.
in the
I
coding.
didn't know what it meant, and it's a sudden and acute onset of whatever.
Yeah. So I don't know if I would just put there per coders. Need to be acute or uh, acute, subacute, or chronic. Because
Right.
fulminant, I think, is
Yeah, that's a
not
sudden onset. So I feel like we should be able to take that versus
Yeah, that's
querying,
right.
and they're gonna, except that the attending didn't say it.
No, that's
So
they didn't
that's a
say it, so
conflicting. So that's where
Mhm.
you could clarify.
you could clarify that. Yes. Yeah, for GI, it's fulminant, so it's, so yeah, that's one of
But do you
another
get that
query
picky at the
opportunities.
same time?
Yeah.
And it,
What would you do, Anne-Marie? What would you do, Christy? Would you query for it or just go with the fulminant?
No, I'd query the attending
Okay.
because they're the captain of the ship, right?
Right.
So I want to clarify: is it acute, subacute, or acute on chronic? More than likely, this is just an acute for this guy. Who knows?
And
But
I
he
might
has
also
alcoholic
give it
liver
another
cirrhosis, so it could be an
24.
acute and chronic, right? So
And I might
you don't
also
want
give
to
it like
guess.
another 24 hours just to see if the attending then sees the GI consult and brings it in. I usually try to give them 24 hours to review that consult.
Right.
yeah, that's
Correct.
right. Yeah.
Very good.
Yeah.
I run a tight ship. They only get a certain amount of time.
Yeah.
That's it. And this is why, this is what we're going to clarify. Is it acute liver failure? Is it acute, subacute, chronic, acute on chronic, or other?
Now,
And then
on this
we'll have it
regard,
specified out.
I had also read, thought it was ACDIS. I can't remember if it was something that came out somewhere else, that we are allowed to, or it's recommended to remove unable to determine from queries. Have you guys?
Yes.
Yeah.
Yeah.
Okay. I thought
Yeah.
so. And I've been actually doing that to try to decrease that aspect. Because if they don't agree with what I gave them, then there's other and they can
Right.
do it.
The only time
According
you
to-
use unable to determine is on your POA status.
Right.
That's
right.
where you use unable to determine. The POA query needs to have that on there because they may not be able to determine if it was present on admission.
Present on
Right.
admission.
Yeah, that I agree with. Yeah.
Okay.
Yeah. And I read that also in ACDIS, but they say it's specifically for POA, but they said also case to case basis, So
Right.
Yeah,
it depends on
right.
the documentation. Like if they're still doing works, workups on this patient, and towards the end they still don't know, we could see how they document.
Yeah, sometimes they don't
I
know.
think, they don't know,
Right.
so still unable to determine. So, but specifically for POA, and the rest is just case. You don't have to use it all the time. It's case to case
Right.
basis. So.
Right. Right. So, okay. Very good. All right. And we were talking about the acute respiratory distress. So, acute respiratory failure specify the type with or without.
Right.
Okay.
So it's important because acute respiratory failure to specify is it what type it is, so it's be more accurate for the coders to code it. So
Right.
is it hypoxic, hypercapnic,
It's like you have
combination,
both.
Or both. Right. Okay. Very good.
And you could see we didn't put their chronic because there's no on the choices, because
Mhm.
there is no documentation that the patient has any respiratory problem before. So you
Yeah.
don't want to give them a choice that is not supported by the documentation.
You don't want to
So
muddy the water, so to speak.
that's right. What if they say chronic? Oops, we have a problem here.
Yeah.
Yeah,
So
take it out. Yep.
yeah, yeah.
Only relevant choices based on your
Mhm.
clinical evidence in the record.
Mhm.
Okay, and then these are just some of the trigger words for like alcohol abuse or intoxication. You want to see if they have alcohol dependence, if they're having hallucinations, agitation, or shaky hands, they could be in withdrawal. And then your elevated ammonia level, liver disease, or they're on lactulose, whether PO or PR. If they have altered mental status confusion, that would be a potential query for your hepatic encephalopathy.
Mm-hmm.
So these trigger words are just you still have to look for the treatment, because it's important that this is being treated before you could code it as a
Right.
diagnosis.
Yeah, because if they're documenting hepatic encephalopathy, but they're not treating
Then
it
yeah,
appropriately
yeah,
as to how it should be treated, then you have to maybe validate that.
that's right. Mm-hmm.
There you go. And then just the queries, the clinical indicators for your acute respiratory failure and chronic. Chronic, we need to know if they're on HOMO 2. And HOMO 2 is continuous. It's not just at night. Or, you got to
Or
make sure
PRN.
that you're on continuous oxygen in order to really capture that chronic respiratory failure. I know some docs are writing it because they have chronic lung disease, interstitial lung disease, or they have COPD end stage and they're on HOMO 2, but they don't wear it all the time. But they're writing that. So, that's something that you may have to clarify as a clinical validation query. Okay.
Yeah, I just I just clarified one with a doc that ED had documented chronic respiratory failure with a recent RSV infection on HOMO 2. And
Right.
the attending was not documenting that. So I didn't want to really do it as a query because I didn't have enough to do that. So it was one the FACI, which I can talk to them so easily. So I did. And I talked to the doctor. I said, are they, still on HOMO 2? Is there chronic respiratory failure? Because this is what ED documented. And he goes, no. He goes, the RSV was a year ago. She did go home on O2. She had it for like 3 weeks. She weaned off of it and they returned the tanks. He goes, she's not a chronic respiratory failure. I said, that's all I needed clarified. Because if I'd have, the way it was documented, you just, I would have almost had to query, but that was an unnecessary query.
Right. Well, even if the provider wrote that in their notes, patient doesn't have chronic respiratory failure, off oxygen for a year since,
Yeah,
COVID.
and he hadn't. That was the thing. He hadn't done that. He had in the medical history of the respiratory failure on HOMO 2, but it was real unclear if that was a true thing by the way he documented that. But then RSV remote RSV is how he put it. So I'm like, okay, that usually implies it's a while back. So,
right.
And yet ED says, recent. So that's why I clarified. And he goes, oh no. He goes, no, I don't consider her a chronic respiratory failure.
Right. Okay. All right. Very good. Let's go through this case study. 46-year-old female.
Sorry.
Oh, that's okay. Yeah, I just want to be sure you're there.
Okay, so it's 46-year-old female admitted with severe abdominal pain, nausea and vomiting, and constipation for approximately 4 to 5 days. Past medical history includes total abdominal hysterectomy for ovarian cancer 3 weeks prior to admission, hypothyroidism, and hypertension. Workup revealed a CT suspicious for bowel obstruction, possibly due to adhesions from prior abdominal surgery. Follow-up CT improving bowel obstruction. Attending provider diagnosed patient with SBO ordered NPO, NG tube to low intermittent suction, and general surgery consult. General surgery consultant notes SPO, continue conservative treatment with NG tube, NPO, and pain control. Follow-up CT in 48 hours to confirm improvement. Okay, so our primary diagnosis here is
Well, the SBO to start.
yes,
And
then,
depending upon further evaluation, what you could query for the type. Is it partial? But I want to say it's partial just by what I see, but that's me as a nurse knowing that versus the doctor saying
the coders. Yeah.
So I
yes.
maybe would want to query just to clarify if it's a partial or complete, just for
complete
notes in the chart.
Anything more?
Well, the ovarian cancer 3 weeks ago, so that's a new thing. So that's a current diagnosis.
That's right.
And doesn't say when they're starting treatment or anything, but if it's 3 weeks ago, that's a current issue.
Yeah, because we don't know whether, they're planning to do chemo there or they're just doing the radiation. So we need to follow up, what their plans are.
I'd have the PDX, the SBO, and then I'd have the ovarian cancer, the hypothyroidism, and the hypertension, and that would be my diagnosis to start.
Yeah. So we have, it's already improving bowel obstruction.
Yeah,
and,
which tells me it's a partial.
Yeah.
I haven't done surgery.
And they say CT says it's adhesions, so it's definitely an obstruction there.
Yeah. Although usually, unless you're doing something funky when you did that hysterectomy, usually that surgery is not going to be your culprit. It's going to be a previous surgery of some sort, because that hysterectomy is so fresh. But then unless something got twisted, you wouldn't know.
That's right. Yes.
Yeah.
Yeah. I mean, it's just 3 weeks ago when they did the hysterectomy, so
yeah, it's pretty fresh.
Pretty fresh for small bowel obstruction. Sometimes it's just gas that doesn't go away.
Or
constipation. I don't see it. Huh? Or constipation. Yes, that's true. Yeah, it's just stuck there. So that's why you need to walk.
That's it.
Well, and thank God we make them move sooner than we used to, because I used to have postpartum C-sections that were on NG tubes because we let them stay in bed.
Yeah, they move them today, that's for sure.
Oh, yeah.
Oh, they do.
Right.
Oh,
Very
yeah.
good.
Those C-sections are up within 12 hours.
Oh, yeah. The doctor's going to be upset if the patient hasn't been up. So.
Oh, yeah. Yeah.
Okay.
So this is just a sample query for the SBO type, Is it something else? Is it just a paralytic, ileus or something going on, So.
Or is it it could be,
is it associated with adhesions or not? You could still ask for partial or, complete too.
Yeah.
That could be another separate query for the type.
Right.
Okay. So. All right. Very good.
If I don't do well, Emery will let me know. Just like I worked with you. I know what you better have.
Then, of course, our trigger words for potential query, you want to see, what their complaints are, and if they're having constipation or something, and what are they doing to treat it? That's the goal for any query too. You need treatment. That three-legged stool, what's documented, what's the workup, and what treatment is performed for all queries.
And case
Okay,
number
we're almost
5.
done with the case studies, I think.
Yeah. So case number 5, 77-year-old male arrived in the emergency room with a nosebleed. Patient states that he is on Eliquis for his chronic atrial fibrillation, and the nosebleed has been going on for several hours. Patient does not admit to feeling lightheaded, as well as has been taking Eliquis as prescribed by his physician. Admission vital signs 97.6, 92 irregular, 14, and 92/56. Workup reveals PTINR of 10 and 3.6 and H&H of 7.2 and 21.1. ENT consulted by ER provider, epistaxis controlled with nasal packing. Attending provider diagnosis epistaxis, hypercoagulable state, chronic AFib, cold Eliquis, serial PT INR levels, 1 dose of vitamin K, and fresh frozen plasma transfusion. So what is our diagnosis here?
Your epitaxis to start.
Yes.
And then I would want to query, because I don't see it linked in this, that the hypercoagulable state and possibly the epitaxis is related to the Eliquis, so you could get an adverse effect.
That's right. Yeah. Because it's
And your
be,
hypercoagulable would go to actually a hemorrhagic disorder if it's related to the anticoagulants.
That's right. Yes. So it's going
and
to be
then
like
watch and see if they get RBCs with a 7.2, because then you could, consider ABLA in there if they document anemia.
Yeah. Yeah, because we have bleeding. And
yeah, we have the source.
H&H.
We have the hemoglobin is 7.2. Right now, they're only got FFP and the vitamin K to reverse.
That's only for the INR, hypercoagulable state. That's right. Yes. So
so I'd watch for anemia for possible ABLA.
And then if they would link the INR to or the bleeding due to Eliquis.
Oh so yeah, I'd be all over that query. Get that link to it.
The patient took it as prescribed, so it's not poisoning. So
yeah, it's not a poisoning; it's just an adverse effect.
Yeah, adverse effect.
But the patient also has AFib.
That's right, chronic AFib. So,
but you do have bleeding going on even in the course of AFib, which you do want an elevated PT and INR for the AFib, but you got bleeding.
That's right.
So, ouch.
Yes. And the patient, it's something chronic, so hopefully they have already, and it's Eliquis. It's not like Coumadin that they have to monitor. I mean, do you still have to monitor Eliquis for INR? Not sure.
No, usually not that much. They're monitoring warfarin, the Coumadin all the time.
Yeah, the warfarin and the Coumadin. I don't see them monitor Eliquis so much.
Yeah. So I mean, the patient's not on Coumadin, so I mean, and H&H is low, so definitely. I mean, the INR is high, so definitely it's
that's probably therapeutic for the patient, but
therapeutic for the patient. Yeah. Yep. So I think that's about it, right?
Yeah, that's it. Very good. And then this is just a sample query. Is it a hemorrhagic disorder? Is it circulating anticoagulants or epistaxis not related to that, and then other?
I need to do a little thing in Word based on your query example here, because I don't know that we have one for that. I think I was trying to make it up or link it, the linking thing.
Yeah, the linking, yeah.
Okay. Yeah. And then these are just the different types of coagulopathy. They could be acquired or inherited. That's where your hemophilia, your factor V Leiden, protein S or C deficiencies. Those are CCs for us as secondaries, and your von Willebrand deficiency. And then case study number 6.
Is a 35-year-old female admitted with nausea and projectile vomiting for several days. Past medical history includes binge drinking, includes every weekend, consists of 3 to 4 alcoholic beverages each day, new onset diabetes per patient diagnosed 1 month ago and non-compliant with oral medication, example metformin, obesity with BMI of 34.1. Workup revealed admitting vital signs, tempo 101.2, pulse of 112, respiration of 24, BP of 1112/56. CT revealed possible inflammation of the pancreatic tail. Blood work, lipase is 12,000, amylase of 567, hemoglobin A1C is 9.7. Attending provider diagnosed with acute pancreatitis, alcohol abuse, and diabetes. Treatment includes NPO, IV fluid at 200 cc per hour, serial lipase, amylase, blood glucose levels daily, insulin sliding scale, and AccuCheck AC and HS, as well as pain control. So our primary diagnosis,
The pancreatitis.
the pancreatitis, acute pancreatitis, right? So do we have any career opportunities here?
Yeah, we need to clarify the diabetes. Us as nurses know it's likely in type 2, but we need to clarify that.
That's right.
Get them to say it. We need
like if the doctor diagnosed controlled, uncontrolled, we still need to clarify, right? With or without hyperglycemia, right? So, yeah.
Where does it say uncontrolled?
No. I'm just saying,
okay.
Sometimes the doctor, yeah. Mm-hmm.
Yeah, we want to clarify that. And then we really want to
Mm-hmm.
watch this chart for alcohol withdrawal.
That's right, for alcohol withdrawal, right? Although we don't have, the patient has abused and for alcoholic beverage each day. So find out, follow up if there's some, withdrawal there.
Yeah.
Cute.
Yeah, I think that's it.
Yeah, just, and follow up, the patient has vomiting, nausea. So just follow up the lights, the patient.
And watch, I don't see a blood sugar here, but you'd really want to watch that with the nausea and vomiting and especially
the
NPO
patient with
status.
diabetes, and non-compliant, right?
Right, because they could be headed to DKA if they're not careful.
Yeah.
Right.
And follow up the obesity also. Is it, it's only 30, 34.1.
Yeah, but we got it documented and we just got to verify the BMI, but.
Yeah.
Yeah.
Mm-hmm.
All right. Very good. And then here's just the sample query for the diabetes, the type,
And now they have a special code for the 1.5.
Oh, really? They do?
They do.
Yeah.
It's other specified diabetes.
Yeah, they do. They added that one last year, I think.
Yeah, because we have one
For this
doctor that
fiscal year.
always is documenting 1.5, but treated as type 2. But with the 1 point, because we didn't have a code for it. So that's how she documented it, because there was not a code for the 1.5. But now.
Oh, really? So she's more specific then.
Yeah. So, yeah. Okay, and then the clinical indicators for your query opportunity for diabetes, which we went through earlier too. So,
yeah.
Thank you for watching. Don't forget to click subscribe, follow, and like buttons. Click the link in the description below to obtain continuing education. CU certificate will be provided after evaluation and tests are submitted.